Now we're about to dive into the heart of musculoskeletal anatomy for step 1, the upper extremities. Let's start with the anatomy of the brachial plexus, which is a good conceptual foundation for understanding the rest of the upper limb. Let's start with the nerve roots, C5 through T1. You'll want to keep in mind though that even though there are cervical nerves 1 through 8, there are actually only how many cervical vertebrae? That's right, 7. C8 comes out below the C7 vertebra, and all the other cervical nerve roots come out above their vertebrae. Let's look at the trunks next, the upper, middle, and lower. After this you get to the divisions, between which there's some crossing over, so the names get complicated and kind of unimportant. Next we get to the cords, which are named for their positions relative to the axillary nerve. The posterior cord splits off into the major extensor nerves of the limb, the axillary and radial nerves, so of course a posterior cord lesion will cause problems with extension. These are part of the last segment, the branches. The others come off the lateral and medial cords and form the musculocutaneous, median, and ulnar nerves. As you can see in the schematic, there are 5 different sets of levels overall in the brachial plexus. You can remember the order of the levels with the acronym Randy Travis drinks cold beer. Alright, now let's turn our attention back to the prior page and look at some of the common injuries. These 4 pictures are really high-yield pictures of the major nerve branches and associated dermatomes for the upper extremity, including the hand. One of these pictures shows the brachial plexus and its distal branches superimposed onto a picture of the hand. It's worth having a rough idea of where each dermatome lies in your mind because many questions will describe paresthesias in patches of skin and require you to know which nerve is involved, so I'd spend some time looking at the diagrams of the dermatomes on the screen here. As for the diagrams of the nerves in the arm and the hand, we'll be referring back to these when discussing injuries in a moment. In terms of lesions, let's start at the top and work our way down. While we won't be discussing all the branches we just mentioned, we'll go through some of the important ones. As we go through this, try to think about what level, that is root, trunk, division, cord, branch, we're at, and then what the mechanism of injury is, and if noted, what injury it causes. The first injury here is the C7 nerve root. If you think about where the C7 root is, you should imagine that only a very central injury could cause this type of problem. Barring something unfortunate like trauma, the common mode of injury for the C7 root, based on its location in the spine, is actually compression of a cervical disc. Next we look at the upper and lower trunk injuries. The upper trunk is most commonly injured by trauma, especially direct trauma to the tip of the shoulder, and is called an Erb-Duchenne palsy, or colloquially as a waiter's tip palsy. You'll see this discussed in much greater detail in just a few pages. In contrast, the lower trunk is not as commonly injured by trauma, though it can be damaged by stretching injuries like trying to grab something while falling, which is something you'll often see on tests. More commonly it's injured by compression. The compression can be from a variety of entities, usually something exotic. Classic board examples would be Pancoast tumors of the lung, that is superior sulcus tumors, which you'll see discussed in depth in the respiratory chapter. You might also see a cervical rib, which is quite literally an additional rib attached to a cervical vertebra. Both cause mass effect on the lower trunk and lead to an array of injuries termed Klumpke's palsy, or total claw hand, which we'll discuss in a few pages. The next set of injuries we'll look at are in the level of the end branches, namely the median, radial, and ulnar nerves. As we discuss these, pay attention to the picture to see what portion of the nerve we're hitting. Namely, is it a proximal portion of the nerve or is it distal? The proximal portion of the radial nerve is the axilla, so you would imagine compression for whatever reason, either having your arm flung over a chair or using crutches incorrectly, would cause it to be injured. Moving along the course of the radial nerve, you'll notice it can be injured in the midshaft of the humerus, as the nerve hugs this part of the bone pretty closely. This occurs in an area known as the spiral groove. Injury to the bone from any type of mechanical trauma could also injure the radial nerve. Move further along the bone, you'll notice more branches begin to appear, particularly as the nerve passes the elbow. If, for example, the radius is dislocated, the deep branch of the radial nerve may be stretched, causing the extensor muscles of the wrist to lose their innervation. If the extensors lose innervation, how would this present? Exactly, it'd present as wrist drop. You'll want to memorize that injury as it's a common one. Now let's turn our attention to another nerve, the axillary nerve. This nerve comes off the brachial plexus early and posteriorly reaches its sites of innervation. The nerve primarily hugs the surgical neck of the humerus. Therefore, if the humeral neck is fractured, it can lead to injury of the axillary nerve. A similar injury would result from dislocation of the humerus or even an IM injection, which often goes into the deltoid muscle, which is innervated strongly by the axillary nerve. On a test, this type of injury would manifest in a patient who has difficulty abducting his or her arm, which is the main function of the deltoid. The next nerve we'll look at is the median nerve. Proximal injuries to the median nerve often don't occur until the median nerve approaches the elbow. When it approaches the condyles, it's vulnerable to compression by a supracondylar fracture of the humerus, which can lead to pronator teres syndrome. When it approaches the condyles, it's vulnerable to compression by a supracondylar fracture of the humerus, which can lead to pronator teres syndrome. Memorize this. More distally, and much more commonly, this nerve can be compressed once it enters the carpal tunnel. In a similar location, it can be compressed by a dislocated lunate bone, another good thing to memorize. Even more distally, the recurrent branch of the medial nerve moves in the direction of the thumb and is a very superficial structure. Superficial lacerations in the right area can injure this nerve. Now let's take a look at the ulnar nerve. Proximal injuries of the ulnar nerve can occur with repeated minor trauma to the medial portion of the arm, where the ulnar nerve is still pretty superficial and accessible. This is the so-called funny bone injury. Proximal ulnar nerve injuries also occur by fracture of the medial epicondyle of the humerus. More distally, the ulnar nerve can be lesioned when it's just beyond the wrist, or it can be lesioned by trauma to the heel of the hand, or a fracture of the hook of the hamate bone, both of which we'll discuss in a moment. Don't confuse the lunate and the hamate in relation to median and ulnar nerve injuries, respectively. The final injury we'll comment on is the anterior interosseous nerve. This is the anterior nerve that exits in part between the radius and ulna and can be compressed in the deep forearm. Okay, now we recognize that was a whirlwind, but remember that we'll try to review the high-yield parts of the image in subsequent sections. Still, we definitely advise coming back to this picture to remember where in the arm the injury often appears. As a little breather, how about we try a question related to this information? Let's say we have a 20-year-old woman who presents to the emergency department with several deep lacerations on the medial side of her wrist after a suicide attempt. She receives prompt psychiatric evaluation. What thumb muscles would be most likely to be affected by these injuries? While this is a difficult question, remember to think about the location of the injury, which at its essence is the opposite side of the wrist and the thumb. Medial wrist injuries affect the ulnar nerve, and one of the only muscles that goes to the thumb that's innervated by the ulnar nerve is the adductor pollicis. The other three pictures, two of the dermatomes and one of the nerves and bones of the hand, are worth going over individually. We'll talk in brief about a couple of points, however, to clarify some injuries mentioned in the prior image. If you recall, we stated that the ulnar nerve can be injured by a fracture of the hook of the hamate. As you can see, the ulnar nerve actually passes through Guillen's canal, which is in part made up of the hook of what bone? That's right, the hamate. The proximity of the two makes it very likely that a fracture of the hamate would lead to an ulnar nerve injury. As you'll note, the flexor retinaculum is well indicated in this picture. This is a structure that creates the anterior boundary of the wrist, such that the median nerve is trapped if any inflammation from repeated trauma occurs. As you work your way through the two dermatome maps, imagine these images superimposed onto your own arms and hands, as it might help you remember the different regions. You can correlate these to the paths of the different nerves in the first image we discussed, and see how nerve roots and nerves move to cutaneous regions that fit their paths and trajectories.